Go ahead and proceed. So when we're dealing with testicular cancer, when you become juniors and seniors on the wards over here, you're going to be seeing a large number of patients with testicular cancer, and you sometimes get diluted into numbers because this is a very rare disease. It accounts for only 1% of all male neoplasms. So in the United States, we will see about 8,000 new cases in this country, and that contrasts sharply with the 230,000 cases of prostate cancer that we'll see, the most common male malignancy, or even the 220,000 cases of lung cancer that we see in the United States. But despite the paucity of cases, this is a very important disease for several reasons. First of all, not that it's not tragic if someone at age 80 dies from prostate cancer. If someone dies from testicular cancer, they literally can lose 50 years of productive life because this is a young man's disease. And most of our patients are in their teens, 20s, or 30s at the time of diagnosis. This has become a model for a curable neoplasm. In the old days, back in the 1970s, in the early 1970s, if a patient had metastatic testicular cancer, the 1-year survival was 5%. Today, we cure 80% of patients that have metastatic testicular cancer. It has also become a model, as is true with childhood acute lymphoblastic leukemia, when you have a curable disease in a young patient population, for looking at the late consequences of therapy, something that we'll get into towards the end of the lecture here. So as far as epidemiology of testicular cancer, 1 out of 400 males in this country will develop testicular cancer. For unknown reasons, this is a Caucasian disease, rare in African Americans, Asian Americans, and Native Americans. The most common incidence in the world is in Scandinavian countries, blonde hair, blue-eyed, Caucasian population. For also unknown reasons, over the last 3 decades, there has been a steady increase in the incidence of testicular cancer. Now, most medical students know about cryptorchidism, and that remains the one and only known risk factor for getting testicular cancer. And that's why, as a pediatrician or an obstetrician, if a male child is born with an undescended testis, you do want to go ahead and surgically repair that, usually by age 3. If you're repairing it after puberty, you just as well, we might as well remove the testis because it's going to be a dead testis and whatever harm has been done has already been generated. Nevertheless, although that's the only known risk factor, with the possible exception of Agent Orange with people that were exposed to it during the Vietnam era, only 10% of patients have a history of undescended testis. So 90% of our young men who have testicular cancer have no known risk factor for developing this malignancy. Now, when a patient presents with testicular cancer, they will usually initially self-discover pain or a mass or a fullness in the testis. They will go to see their primary care doctor, and a lot of times the primary care doctor is appropriately thinking of common disease, epididymitis, orchitis, torsion, or even an inguinal hernia, rather than a rare disease like testicular cancer. But you do want to do a careful physical examination. And if you feel a mass within or around the testis, or you're not sure what you're feeling on physical examination, you want to do a testicular ultrasound. A testicular ultrasound, if there's a solid mass within the testicular parenchyma, it will show up as a hypoechogenic mass. There is no differential diagnosis. When you have a mass within the testis, it is cancer. And when that is the situation, the patient will be referred to a urologist. The urologist will make a high inguinal incision, remove the testis, and our friendly neighborhood pathologist will tell us what cell type we are dealing with. Now, from a clinician's point of view, we talk about 2 different forms of testicular cancer: seminoma and everything else that we simply call non-seminomatous germ cell tumor. We make this distinction because seminomas is in an older patient population, 30s, 40s, and 50s. It is uniquely sensitive to radiation therapy when we have small volume localized disease. It grows more slowly. It is usually confined to the testis or to the retroperitoneal lymph nodes. And as far as our tumor markers, HCG and AFP is always normal with seminoma, and HCG is usually normal with seminoma. So we do have some clinical differences, which is why we distinguish them. And in the field of hematology oncology, we have a lot of non-seminoma, non-Hodgkin's lymphoma, non-small cell lung cancer, because we have different clinical characteristics and treatment based upon the histology. Well, as far as the staging workup, once the urologist has done a radical orchiectomy, and once the pathologist has confirmed the diagnosis and told us the cell type or types, we then want to stage the patient as we do in oncology with any tumor, so we can determine what type of therapy should be done. If a patient has stage 1 disease, that means it's confined to the testis. Usually orchiectomy alone is all that is necessary. If a patient has stage 2 disease, that's spread to the retroperitoneal lymph nodes, and if it's small volume disease less than 3 centimeters, it will be treated with localized therapy. For seminoma, radiotherapy. For non-seminoma, a good urologist will do a retroperitoneal lymph node dissection. If we have bulky, greater than 3 centimeter stage 2 disease, or stage 3 disease, which means pulmonary metastases, or supraclavicular or mediastinal adenopathy, the patients will go to chemotherapy. So we do a history and physical examination. Most of the patients are asymptomatic post-orchiectomy. They may have back pain because of retroperitoneal lymph nodes. In physical examination, they may have palpable supraclavicular lymph nodes. We have the quintessential tumor markers, which we wish we enjoyed in all forms of oncology: human chorionic gonadotrophin and alpha-fetoprotein. And LDH is like a SED rate. It is not a tumor marker. There is nothing specific about an elevated LDH, but nevertheless it is sometimes of some minimal value in evaluation of patients. We know this disease will spread lymphatically to the ipsilateral retroperitoneal lymph nodes. Ergo, we do an abdominal CT scan. We know it can spread hematogenously to the lungs, and we'll do a chest x-ray, and if necessary, a chest CT scan to determine the stage of the patient. Now, way back in the 1960s and the early 1970s, the standard treatment for metastatic testicular cancer is an older drug called actinomycin D. And even in those ancient times, there were occasional cures with metastatic testicular cancer with actinomycin D. And sadly, in the world of oncology, when we look at a 5 to 10% cure rate, which seems so unsuccessful on testis cancer, we would love to be curing 10% of metastatic lung cancer patients or colorectal cancer patients or many other common diseases that we see in an oncology clinic. Well, in the early 1970s, 2 other drugs became available that were competitive with but not superior to actinomycin D, namely vinblastine and bleomycin. And the 2-drug combination of vinblastine and bleomycin was found to be superadditive or synergistic, showing a higher cure rate than one could predict from the single agent activity, with 5% cure rates with single agents and 25% cure rates with the combination. But what really revolutionized the cure rate of this disease was the discovery of the first heavy metal ever to be used as an anti-neoplastic agent. So let's go way back in time to the late 1960s and 1970s. We had alkylating agents like nitrogen mustard, cyclophosphamide. We had antimetabolites like methotrexate. We had antibiotics, vinca alkaloids like vincristine or vinblastine. In breast cancer and prostate cancer, we had hormonal therapy. We were just beginning to look at some other type of novel agents, but there never was a thought of a metal as an anti-neoplastic agent. Well, in the late 1960s, there was thought that physical agents could enhance the ability of drugs or radiation to get through the cell membrane and into the cancer cell. And so a typical whipping boy for looking at DNA was to set up a water bath solution, dump E. coli in the water bath solution, and just see what the effect of an electrode, namely electrolysis, would be as a potential adjunct to radiation or chemotherapy. And a very talented biophysicist at Michigan State, Dr. Barnett Rosenberg, did this experiment, dumping the E. coli and looking at the electrodes and running this electric current. And he found a profound biological effect that he could not explain by the electric current per se. And this is where serendipity and knowledge and luck comes into play. He realized that perhaps it was something in the electrodes that was secreted into this water-based solution. And you guessed it, they were platinum electrodes. It was called cis-diamine dichloroplatinum. And that generated the first time anyone had ever thought of looking at such an agent as an anti-neoplastic agent. Now, when we look at combination chemotherapy 40 years ago or 4 minutes ago, the concepts are the same. We want drugs that have known single-agent activity, different and unique mechanisms of cytotoxicity, non-overlapping toxicity, different mechanisms of action, non-overlapping toxicity, and also not just an additive, but a super additive effect. One of the unique things about platinum, unlike any other drug that we use in oncology, it is synergistic with a wide, broad panoply of different cytolytic anti-neoplastic agents. So in 1974, when I was a brand new department member here at Indiana University, we looked at our original, what was called PVB regimen, cisplatin, vinblastine, bleomycin. So vinblastine and bleomycin was already established as a true drug regimen, and cisplatin was an experimental drug that had been looked at in many different tumor types, one of them being testicular cancer. When the original phase 1 studies were done with platinum, the drug was felt to be too toxic for usage and was about to be discarded because of severe nausea and vomiting, neurotoxicity, ototoxicity, and acute renal failure. What saved platinum from extinction is testicular cancer, because the responses were spectacular in this individual disease. If a drug works, an oncology community will figure out how to mitigate the toxicity, which has been done several decades ago with this drug. And it's interesting to note, 40 years later from the first studies with platinum, platinum now represents first-line therapy in 13 different types of tumor. It happens to be that testicular cancer remains the only tumor where there are spectacular results, but this is still a standard therapy in many different diseases. So this was our first PVB study, done as a phase 2 study here at Indiana University in a contemporaneous time when actinomycin D was standard therapy worldwide with a 5 to 10% cure rate. And even in my youthful exuberance at that time, I never would have dreamed that we literally would have had a 1 log increase in the cure rate by the introduction of platinum combination chemotherapy. Well, after that phase 2 study was done from 1974 to 1976, and this truly is the history of medicine over here, we began to appreciate the fact that this very high cure rate was not due to the older drugs, but due to this novel new agent, cis-diamine dichloroplatinum, or simply platinum. So we then did a series of phase 3 studies asking a clinically relevant question that we felt we could answer. This study over here wanted to see if we could reduce the dosage of vinblastine that would therefore mitigate neuromuscular toxicity and hematological toxicity by 25% and still maintain the same high cure rate. We also looked at adding a fourth drug, doxorubicin or adriamycin, at the same time as a 3-arm clinical trial. In this particular small phase 3 study in 78 patients, whether patients got higher dosage of vinblastine or lower dosage of vinblastine, there really was no evidence that we were improving the cure rate by the higher dose of vinblastine. A much larger study was done in Europe confirming these same results in this small phase 3 study, thus showing we can safely reduce the toxicity and maintain therapeutic efficacy. Well, in 1978, we did one of our most important phase 3 studies, and we challenged one of the basic tenets at that time in oncology. And this was a pediatric childhood leukemia tenet, that in order to successfully treat a curable patient with a malignancy, we had to give induction therapy followed by long-term maintenance therapy, and that was the standard all throughout the decade of the 1970s. So we challenged that by doing this randomized study. After 12 weeks of therapy, patients were randomized to a control arm to give a total of 2 years of therapy versus an experimental arm of stopping all therapy after 12 weeks. And in this study, in a randomized fashion, we found that whether patients did or did not get an additional 20 months of maintenance Velvan vinblastine, there was absolutely no difference in the cure rate in our patients who achieved a complete remission with induction therapy. So looking at these older studies from the 1970s and early 1980s, it's also interesting to note that the number of patients who were cured has gone from 57 to 73 to 80%. Not because of more aggressive therapy, longer duration of therapy, or adding new drugs, but just more familiarity with the regimen, more judicious use of surgery to resect residual disease, a better definition of complete remission with more refined CT scans, and this shows some of the hazards of what we call historical controls. If this were a brand new regimen with PVB, and we were comparing it to an older regimen as historical control, we might have deluded ourselves to thinking we have made a major advance when it's just the hazards of historical control, better patient population, etc., etc. Well, if a treatment works in Indiana University, it should work nationwide. And this is SEER data from the NCI that was published in the Journal of Clinical Epidemiology back in 1991, showing what the cure rate for all patients, including those cured with surgery, was up until the time that we started our PVB trial, presented it at a scientific meeting, and published it in a medical journal, showing nationally this strong upward swing in the cure rate in this disease with testicular cancer. And just to show you a couple of the patients that we treated in this earlier time period, this is one of our patients who came in critically ill, severely hypoxic, as you can see on his lateral. He literally has complete replacement of his pulmonary parenchyma with metastatic chorioid and embryonal carcinoma. Now, if this were any disease other than testis cancer, with such a poor performance status, this patient would not have even been offered chemotherapy and would have gone straight to hospice. But this is testis cancer, and this is one of our many cures from the 1970s. This is another patient with choriocarcinoma with literally more white than black on the chest x-ray. Again, cured of his disease with his platinum-based chemotherapy. And finally, this is a patient, not finally, but this is one of our patients who also had extensive liver metastases as well as pulmonary metastases, again, with regression of all his disease with chemotherapy. And the final picture here, this is one of our patients with mediastinal adenopathy from his testicular cancer, and this is 1 week later with complete disappearance of this disease. So this is truly a unique drug in a unique disease, and is a luxury and a privilege to be able to see a patient with metastatic disease, to be able to look them in the eye and tell them that our goal is not merely palliation of symptomatology or a modest prolongation of survival, but our goal was cure, and we usually achieve that cure. Well, we talked about synergism before, about drug-drug interactions. It's easy to document synergism in a mouse model. You inject tumor cells into the ventral surface of a mouse, wait until you have visible tumor nodules, and then you give drug A and see if you get prolongation of survival, drug B, and then you combine drug A and drug B. And this was done by Dr. Shabrell of the Southern Research Institute in Birmingham, Alabama, showing that if you do nothing after the tumor is implanted, the mice die very quickly. Cisplatin, a couple of days, prolongation of survival. A then newer drug, VP16 or etoposide, a couple of weeks prolongation of survival, but the mice all died. But when the two drugs were combined in this murine model, a 25% cure rate. And this is a nice example of synergism in a preclinical model. So with that as a background, we looked at etoposide as a single drug, because we first have to show that a drug has single agent activity before doing it as part of a combination chemotherapy. So patients who got etoposide achieved partial remissions, but no cures with etoposide. If a patient failed to be cured with PVB, and we just gave them single agent platinum, we wouldn't even see any long-term remissions and certainly no cures. So we looked at this two-drug combination that was synergistic in the murine model, cisplatin and VP16 or etoposide, in patients who failed to be cured with platinum, vinblastine, bleomycin. And much like the animal model, we cured about 1/4 of these patients with this then experimental program. And this was the first time in an adult solid tumor that we had actually achieved cure as second-line or salvage chemotherapy. So with that as a background, our next phase 3 study was comparing PVB, no maintenance therapy, lower dose of vinblastine, versus what we call BEP, bleomycin etoposide cisplatin. Simple substitution, etoposide instead of vinblastine. So before the first patient entered this phase 3 trial, we knew that the BEP arm would be less toxic because it doesn't have the ileus, the jaw pain, the neuromuscular toxicity that vinblastine does. And these are the results in 244 patients. Not only did we ameliorate toxicity, but we improved therapeutic efficacy with a higher cure rate. So when this study was finished in 1984, this eliminated PVB forevermore as far as in our literature with testicular cancer in favor of bleomycin etoposide platinum, or BEP. Well, over these years, with our metastatic patients, we looked at what affects our ability to cure disease. And not surprisingly, the larger the volume of the disease, the more multiple sites of disease, the lower the cure rate. We also learned that the amplitude of elevation of HCG and alpha-fetoprotein were independent prognostic variables. The higher a tumor marker, regardless of volume of disease, the lower the cure rate. So we defined patients that were felt to be good risk disease with high probabilities of cure, and we randomized them to the control arm of BEP times 4 versus BEP times 3. Now this was not just reduction of a course of therapy, but this was elimination of the most toxic course of therapy because of cumulative anorexia, nausea, and vomiting, neuro and ototoxicity with platinum, the rare cumulative leukemia from etoposide, and the potential for cumulative pulmonary fibrosis with bleomycin. So again, going into this trial, we knew that we were potentially eliminating the most toxic of the 4 courses of therapy. So 184 patients entered this study. Our definition of good risk disease was very excellent, as over 92% of these patients were cured of their disease, being continuously showing no evidence of disease, with not even a 1% difference between 3 courses versus 4 courses of therapy. So over a decade, from 1974 to 1984, we went from all patients getting 2 years of chemotherapy to patients getting just 12 weeks of chemotherapy to patients now, for the most part, just getting 9 weeks of chemotherapy based upon random prospective clinical trials, phase 3 studies showing the importance of asking a relevant question and being able to answer it not by a guess, but by doing a phase 3 clinical trial. Well, this is the current germ cell consensus classification as to who needs more than 3 courses of therapy. And these are the patients that have advanced disease or intermediate risk disease based upon amplitude of tumor markers or presence of liver, bone, and brain metastases. So how do we treat patients that have poor risk disease with more massive disease with sky-high tumor markers? Well, 4 courses of BEP is the standard and still is today. This is a negative phase 3 clinical trial that was not productive, where we randomized patients to a drug called ifosfamide, an analog of cyclophosphamide, a bifunctional alkylating agent, as opposed to bleomycin. So again, it's a substitution of ifosfamide for bleomycin. We knew ifosfamide is a lot more toxic than bleomycin, but we hoped it would have a higher cure rate. Unfortunately, it had basically the same cure rate with no evidence of benefit with the more toxic, what we call VIP regimen. But even negative trials can give us useful information. There are some patients who simply cannot take bleomycin because they have inherent lung disease, or they're over age 50, where this drug is a very dangerous drug. So we know that we can give this regimen and not harm the patient as far as lowering the cure rate. And perhaps our most famous patient in happier days over here, Lance Armstrong, this is after he won his first of the Tour de France's, he never got bleomycin for a very different reason. We had just finished this study, and his main goal was to be cured of his cancer, and a distant second goal was to return as a professional athlete. He knew that if he got 12 weeks of bleomycin, it would lower his diffusion capacity. Now, I dare say there's not a single person in this room, if you got 12 weeks of bleomycin, it would affect your livelihood in any way whatsoever. But if you're a long-distance marathon runner or doing something like the Tour de France, a 1% reduction in your diffusion capacity is going to lower your athletic performance. So knowing that he would have more nausea and vomiting, more myelosuppression, he opted for VIP after that study was done, as opposed to BEP. Now this is a less famous athlete, unless you're from India. This is UV Singh. And UV Singh is the world's #1 cricketer. He led India to the World Championship, and this is a more popular sport worldwide than even the Super Bowl is in American football. So he came to Indiana University for his treatment, been cured of his disease with his testicular cancer. So what do we do in 2014 if we fail to cure a patient with first-line therapy with testicular cancer? The rationale for second-line or salvage therapy is to do something different. If you give the same identical drugs, you get the same result, remission, and disease is right back again. So we tend to look at high-dose chemotherapy with what used to be called bone marrow, but is now called peripheral blood stem cell transplant. Now there's nothing magic about the transplant. This is an auto transplant from self, not an allo transplant from an HOA-related sibling. So there is no graft versus tumor response, nor is there any toxic graft versus host response. The transplant is simply to allow us to give 5 times the dosage of myelosuppressive drugs that would normally be lethal, but they're not, because we infuse hematopoietic stem cells by now doing it with peripheral blood stem cell transplant. Now this has been a failed strategy in breast cancer. And it was a failed strategy in breast cancer despite the initial hype, because again, there's nothing about the transplant that has to do with the drugs. You can only transplant people with drugs whose major toxicity is myelosuppression. In breast cancer, the best drugs are the taxanes and doxorubicin. You cannot give 5 times the dosage of those drugs because of cardiomyopathy from the doxorubicin with congestive heart failure, and because of encephalopathy and neurotoxicity if we give very high dosages of paclitaxel or docetaxel. So giving poor drugs in high dosage is not going to do the difference. Well, in testis cancer, the second best drug is etoposide. Its dose-limiting toxicity is myelosuppression. The best drug is cisplatin. We cannot give cisplatin in 5 times the dosage, where the patients would be on dialysis, would be deaf, and would be crippled with severe neurotoxicity. Again, the hematopoietic stem cells only protect from myelosuppression, not non-myelosuppressive toxicity. So an analog of cisplatin is carboplatin. It is minimally less effective than cisplatin in testis cancer, but its dose-limiting toxicity is myelosuppression. So this is a regimen that we've used with carboplatin and etoposide or VP16, giving 2 courses of high-dose chemotherapy at 3 to 4 week intervals. And this is a study that we had published back in 2007 in the New England Journal of Medicine. This was a large phase 2 study. And I think one of the most remarkable things in testicular cancer is not that we cure people with first-line therapy, but we can cure people who fail to benefit from first-line therapy. When transplant is used as second-line therapy in 135 patients, we cure 70% of the patients. Even when it's used as third-line therapy, we cure 45% of the patients. If a patient is refractory to platinum, that means that the patient progressed within 4 weeks of standard dose platinum. We can still cure the patient with high dose platinum, as seen in the numbers over here. Well, when we look at the acute toxicity of chemotherapy, our patients are well aware and very familiar with this. Nausea and vomiting has been greatly mitigated with the introduction of the first 5-HT3 receptor antagonists ondansetron. In the 1970s, when a patient would get day 1 of cisplatin, despite giving phenothiazines, which is like a placebo when we're using for these drugs, like chlorpromazine or propylthorazine, or excuse me, Comazine and Thorazine. I can't remember the generic names, we don't use them anymore. So the average number of emetic episodes on day 1 was 12. Can you imagine that? 12 emetic episodes, and you got day 2, 3, 4, and 5 coming up, and 3 weeks later your next course, 3 weeks later your next course, and 3 weeks later your 4th and final course. Today, the median number of emetic episodes on day 1 is 0. Patients still get chemotherapy-induced nausea, they get occasional vomiting, but nothing like it used to be before we had the 5-HT3 receptor antagonist. Alopecia is not preventable, it is temporary. Fatigue is during the periods of myelosuppression and is temporary. Myelosuppression can cause thrombocytopenic bleeding, which can be fatal, granulocitopenic fever, which can be fatal, but it's very rare for a young healthy patient, rare being well under 1%, to die of a myelosuppressive complication. Mucocutaneous toxicity, primarily stomatitis, is seen with bleomycin. Cumulative peripheral neuropathy from platinum. Bleomycin can cause cumulative pulmonary fibrosis, which in very, very rare cases can be fatal. And nephrotoxicity, which used to be such a problem in the phase 1 trials of platinum, have been simply mitigated by saline hydration. Nothing exactly brilliant, but when we look at other heavy metals like mercury that cause acute proximal tubular necrosis, platinum does the same. It's very easy to prevent nephrotoxicity. You make sure the patient is well hydrated before you start the drug, and you want to make sure the drug does not accumulate in the proximal tubules of the platinum, and to ensure adequate urinary excretion, which we do by giving continuous saline hydration. So the nephrotoxicity that made us fear that platinum would never get off the ground in the early 1970s is almost a non-issue after the advent of just simple saline hydration. Now, less appreciated by patients and perhaps by physicians are late consequences of therapy that can happen years or decades later. The most feared is second malignancies. We know with etoposide that when we give 4 courses or less of etoposide-based therapy, that about 1 out of 500 patients will get acute leukemia because of the drug. If we have to do high-dose chemotherapy with high-dose etoposide on the transplant unit, about 3% of patients will get acute leukemia. Also, giving platinum, it does have alkaline agent type of activity, and it can lead to other second malignancies, whether they be bladder cancer, prostate cancer, colorectal cancer, lung cancer, a variety of other malignancies. We have studies looking at the incidences. It is rare, but it is certainly higher than the patient population that has never had platinum chemotherapy. Cardiovascular disease. There are a variety of reasons why people get cardiovascular disease, especially if they've had radiation therapy for seminoma, but also with chemotherapy. We offer sperm banking prior to starting chemotherapy. 60% of patients who are cured will have normal return of their sperm count within about a year after completion of their therapy, but 40% will be permanently oligo or even azospermic. So sperm banking is offered. This is due to platinum-based chemotherapy. Hypogonadism is often not recognized. Most patients are aware if they have erectile dysfunction with difficulty having and maintaining an erection, that is a sign of hypogonadism. Also muscle weakness or fatigue. Less well known are insomnia, depression, irritability, and when women go through menopause, they have hot flashes. When men have low testosterone, they have increased sweating and especially night sweats. We ask patients about those symptoms. We replace testosterone. This is not a hormonally mediated disease like prostate cancer. Some doctors say, gee, if I give testosterone, I'll flare up the cancer. Certainly not true. Now, also less well known by patients and physicians is metabolic syndrome. Metabolic syndrome can be attributed to chronic hypogonadism. So it's not just the irritating symptoms that patients have, but it can lead to the cardiovascular disease that can be seen as a late complication. So metabolic syndrome is comprised of insulin resistance, hypertriglyceridemia, hypertension, truncal obesity, and again, this is a treatable cause of a late complication of therapy. And we want to be aware when we follow our patients, we're not just following them for recurrent disease, but looking at overall health issues, smoking cessation, weight reduction, checking their blood pressure, checking their lipid profile, and also checking their testosterone level as clinically indicated. So preventative strategies for these late complications. We've done some of this already with reducing duration of therapy. We used to give radiation therapy for stage 1 seminoma. We don't do this anymore. We prefer observation or surveillance. Cardiovascular disease we talked about already, fertility with sperm banking. And this is a very sobering slide over here, as will be the next one. When a patient gets intravenous chemotherapy with platinum, and you look at doing spectroscopy and measuring platinum in the serum or urine, 10 years later and 20 years later, the platinum is still there. And this is probably part of the reasons with looking at second malignancies and cardiovascular disease. We have long-term follow-up because we started in 1974 with a curable patient population. But again, we're not going to not give platinum to a curable disease that used to have a 5% cure rate, but we need to be aware of this data. And this is the other study looking at a similar type of thing published in the journal Clinical Oncology, showing that chronic neuropathy is associated with higher levels of platinum in the serum and the urine years and years after completion of therapy. So we currently have an NCI grant that we're the major contributor to. This will look at over 3,000 patients who have treated with platinum-based therapy from 1980 on, who have at least a 1-year follow-up after completion of their therapy. We will be looking at genetic susceptibility, looking at various SNPs to see what predicts for developing toxicity. This first study will actually just look at neuro and ototoxicity, and a subsequent study will look at this more important cardiovascular toxicity and second neoplasms. So finally, when we look at why do we cure this disease, and we don't cure lung cancer, breast cancer, colorectal cancer, or the more common solid malignancies, well, first of all, it's a young patient population with a rapidly proliferating tumor that can tolerate aggressive chemotherapy, but that's not very important. That's true with a lot of other diseases. It's a chemosensitive tumor with a high CR rate. We get a high CR rate with small cell lung cancer, but virtually everyone relapses. The third bullet point here is important. Having an HCG and AFP to define when to stop therapy and when to start therapy is very, very important. We also have combined modality therapy that we can surgically resect persistent disease that is localized and is not cured with chemotherapy alone. But the main reason for the high cure rate is we have a low relapse rate. We get complete remissions with many other solid tumors, but they eventually relapse 3, 6, 9 months later. Once we achieve a complete remission, the relapse rate is only 5% in this disease. So why do we have a low relapse rate? First of all, even in widespread metastatic disease, our patients are immunocompetent. Secondly, and it's hard to prove or disprove this, germinal epithelium may be less prone to somatic mutations. It's easy to get a remission with chemotherapy, but drug resistance eventually develops in solid tumors. It doesn't in testis cancer for unknown reasons, and this may be one of them. We have absence of mutated p53 and absence of the multi-drug resistance gene, where a drug will go into the cancer cell and have rapid efflux right out of the cancer cell. And I think this last bullet point is something that John Turchi and others in our laboratories are very much involved with, and that's DNA repair. DNA is a major site of activity for platinum as it is for many other agents. And mechanisms of drug resistance have to do with DNA repair. Germ cell tumor cells have a reduced capacity for nucleotide excision repair, and unrepaired damage leads to apoptosis. And again, looking at DNA repair is one of the reasons why these complete remissions are durable rather than temporary. So despite our concerns, and they are real concerns about late consequences, which probably affect maybe 1 to 3% of our cured patients, higher than the general population, we don't want to lose fact of the main issues with testis cancer. This is survival curves BC, before cisplatin was available. If you had stage 1 or stage 2 disease, these were your surgical cure rates. In an actinomycin D era, we were curing 5% of patients when they had stage 3 disease. By contrast, this is what we do worldwide in young men with testicular cancer. Virtually all patients with local regional disease are going to be cured with surgery, or if they relapse, subsequent chemotherapy. Those patients who present with stage 3 disease will have an 80% cure rate. So overall, 95% of these patients are cured. So this, I hope, has been an example of looking at experimental drugs such as platinum, not giving up because of toxicity when we see therapeutic efficacy, at least in this individual tumor, testicular cancer, doing appropriate clinical trials and answering questions by randomized studies rather than historical controls. And if we can do these type of studies and get these type of results in testicular cancer, hopefully as you mature in your career, as we learn more about personalized medicine, more about genomic abnormalities, that we will develop similar type of strategies for other tumors as well. Well, thank you very much for your attention.